Question 1. The review process indicates a physician is considering a new treatment modality for a common chronic condition based on a recently published randomized controlled trial. Which of the following represents the most appropriate approach to critically appraising this study for potential integration into clinical practice? Option A. Prioritizing the anecdotal experiences of colleagues who have already adopted the new treatment modality. Option B. Evaluating the study's methodology for potential biases, assessing the appropriateness of the statistical analysis, and considering the generalizability of the findings to the physician's patient population. Option C. Relying primarily on the impact factor of the journal in which the study was published and the known reputation of the principal investigator. Option D. Focusing exclusively on the p-values reported in the results section to determine statistical significance. Correct answer is B. Evaluating the study's methodology for potential biases, assessing the appropriateness of the statistical analysis, and considering the generalizability of the findings to the physician's patient population. Explanation. The review process indicates a physician is evaluating a new study for potential integration into their clinical practice. This scenario is professionally challenging because it requires discerning the validity and applicability of research findings to patient care, a core competency for internists. The physician must move beyond simply reading a study to critically appraising its methodology, results, and conclusions to ensure patient safety and optimize treatment efficacy. This demands a nuanced understanding of research design, statistical interpretation, and the potential for bias. The correct approach represents best professional practice because it prioritizes a systematic and evidence-based evaluation of the literature. This involves assessing the study's internal validity, e.g., appropriate control groups, blinding, randomization, and external validity, generalizability to the physician's patient population. Adherence to the principles of critical appraisal ensures that clinical decisions are informed by high-quality evidence, aligning with the American Board of Internal Medicine's commitment to lifelong learning and the delivery of evidence-based medicine. This process directly supports the physician's responsibility to provide the best possible care, minimizing the risk of adopting ineffective or harmful treatments. An incorrect approach that focuses solely on the statistical significance of the results without considering the study's design or potential biases is professionally unacceptable. This failure represents a disregard for the fundamental principles of evidence-based medicine and can lead to the adoption of spurious findings. It also overlooks the ethical imperative to base clinical decisions on robust evidence, potentially exposing patients to unproven or detrimental interventions. Another incorrect approach that relies on the reputation of the journal or the lead author without independent critical appraisal is also professionally deficient. While journal impact and author expertise can be indicators of quality, they are not substitutes for a thorough evaluation of the study's methodology and findings. This approach risks perpetuating the influence of potentially flawed research and fails to uphold the physician's duty to critically evaluate all evidence. A further incorrect approach that prioritizes anecdotal evidence or personal experience over the systematic evaluation of the published literature demonstrates a failure to engage with the core tenets of evidence-based practice. While clinical experience is valuable, it must be integrated with, not replace, the critical appraisal of peer-reviewed research. This approach can lead to practice patterns that are not supported by the best available evidence, potentially compromising patient outcomes. The professional reasoning process for similar situations should involve a structured approach to literature appraisal. This includes 1. Defining the clinical question, 2. Searching for relevant literature, 3. Critically appraising the identified studies for validity and applicability, 4. Integrating the evidence with clinical expertise and patient values, and 5. Evaluating the outcomes of the implemented changes. This systematic process ensures that clinical decisions are grounded in the highest quality evidence and are tailored to individual patient needs. Question 2. Which approach would be most appropriate for a patient presenting with moderate depressive symptoms and significant anxiety, who expresses a desire to try to manage it on my own for a bit longer before considering medication, despite the physician's concern about potential symptom escalation? Option A. Acknowledge the patient's request but proceed with initiating a moderate dose antidepressant, emphasizing that delaying treatment for moderate depression and anxiety can lead to poorer long-term outcomes and that their current feelings are not conducive to effective self-management. Option B. Inform the patient that their current reluctance to engage in evidence-based treatment puts them at significant risk and suggests they seek care from a different provider who may be more amenable to their approach. Option C. Engage in a detailed discussion about the patient's specific concerns regarding medication. Explore non-pharmacological interventions such as psychotherapy and lifestyle modifications, and collaboratively develop a plan for close monitoring with clear criteria for initiating pharmacotherapy if symptoms worsen or the patient's perspective changes. Option D. Prescribe a selective serotonin reuptake inhibitor, SRI, at a low dose, explaining that it is a standard first-line treatment and that the patient can discontinue it if they experience side effects, without further exploration of their stated preference to delay. The correct answer is C. Engage in a detailed discussion about the patient's specific concerns regarding medication. Explore non-pharmacological interventions such as psychotherapy and lifestyle modifications, and collaboratively develop a plan for close monitoring with clear criteria for initiating pharmacotherapy if symptoms worsen or the patient's perspective changes. Explanation: this scenario presents a common clinical challenge in managing depression and anxiety, balancing patient autonomy with the physician's duty of care, particularly when a patient expresses ambivalence about treatment. The physician must navigate the patient's right to refuse or delay treatment against the potential for worsening symptoms and the risk of harm. The American Board of Internal Medicine, ABIM, emphasizes evidence-based practice, patient-centered care, and ethical considerations in its examinations. The correct approach prioritizes shared decision-making and a thorough assessment of the patient's understanding and capacity. It involves exploring the patient's concerns, providing comprehensive information about treatment options, risks, and benefits, and collaboratively developing a plan that respects the patient's values and preferences while ensuring ongoing monitoring and support. This aligns with ABIM's focus on ethical medical practice and patient engagement. An incorrect approach that involves immediately escalating pharmacotherapy without fully addressing the patient's stated concerns or exploring alternative interventions fails to respect patient autonomy and may lead to non-adherence or adverse effects. Another incorrect approach that involves dismissing the patient's concerns and proceeding with a treatment plan against their expressed wishes constitutes a violation of ethical principles and potentially patient rights. Finally, an approach that involves withdrawing from the patient or delegating the entire management to another provider without adequate transition of care, or addressing the underlying issues, is also professionally unsound and ethically problematic. Professionals should employ a systematic decision-making process that begins with a comprehensive assessment of the patient's condition, followed by an open discussion of treatment options, risks, and benefits. This discussion should be tailored to the patient's understanding and incorporate their values and preferences. When a patient expresses ambivalence, further exploration of their concerns, fears, and expectations is crucial. The goal is to reach a shared decision that the patient understands and agrees with, even if it involves a phased approach or a period of observation, with clear plans for follow-up and reassessment. Question 3. System analysis indicates a 68-year-old male with a history of hypertension and type 2 diabetes presents with new-onset exertional dyspnea and fatigue. He denies chest pain, palpitations, or edema. His current medications include lisinopril and metformin. Physical examination reveals mild bibasilar crackles but no murmurs or significant peripheral edema. Initial laboratory workup is unremarkable. The patient expresses significant anxiety about undergoing invasive diagnostic procedures. Which of the following approaches best addresses this clinical scenario? Option A. Prescribe a trial of high-dose diuretics and beta-blockers empirically to manage potential heart failure symptoms, pending further evaluation. Option B. Initiate a comprehensive non-invasive workup including an electrocardiogram, chest X-ray, echocardiogram, and pulmonary function tests to establish a baseline and refine the differential diagnosis before considering invasive options. Option C. Proceed directly with cardiac catheterization to definitively rule out coronary artery disease, given the patient's age and exertional symptoms. Option D. Focus on optimizing his diabetes and hypertension management, assuming his symptoms are primarily related to uncontrolled comorbidities. The correct answer is B. Initiate a comprehensive non-invasive workup including an electrocardiogram, chest X-ray, echocardiogram, and pulmonary function tests to establish a baseline and refine the differential diagnosis before considering invasive options. Explanation: scenario analysis. This scenario presents a common challenge in internal medicine, where a patient's complex medical history and current presentation necessitate a nuanced approach to diagnosis and management. The physician must balance the need for thorough investigation with the patient's well-being and the potential for iatrogenic harm. The patient's reluctance to undergo invasive procedures adds a layer of ethical consideration, requiring shared decision-making and respect for patient autonomy. Correct approach analysis. The correct approach prioritizes a comprehensive, non-invasive initial assessment, leveraging existing diagnostic tools and patient history to formulate a differential diagnosis. This aligns with the American Board of Internal Medicine's emphasis on evidence-based medicine and patient-centered care. It reflects a commitment to minimizing unnecessary interventions, reducing patient risk and cost, and respecting patient preferences, all of which are core tenets of ethical medical practice. This approach allows for a systematic evaluation, building a strong foundation for subsequent diagnostic or therapeutic decisions. Incorrect approaches analysis. An approach that immediately escalates to highly invasive diagnostic procedures without a thorough non-invasive workup fails to adhere to the principle of judicious resource utilization and patient safety. It risks exposing the patient to unnecessary complications, discomfort, and expense, which is contrary to best practices in internal medicine and ethical guidelines that mandate minimizing harm. An approach that relies solely on empirical treatment without a clear diagnostic hypothesis or adequate investigation overlooks the importance of accurate diagnosis. This can lead to delayed or incorrect treatment, potentially worsening the patient's condition or masking a more serious underlying pathology. It deviates from the systematic diagnostic process expected of internal medicine physicians. An approach that dismisses the patient's concerns or preferences regarding invasive procedures, proceeding without adequate shared decision-making, violates the ethical principle of patient autonomy. It undermines the physician-patient relationship and can lead to patient non-adherence and distrust. Professional reasoning. Professionals should approach such cases by first conducting a thorough history and physical examination. This should be followed by a systematic review of prior investigations and consideration of non-invasive diagnostic modalities. A differential diagnosis should be formulated, and the risks and benefits of further investigations, including invasive procedures, should be carefully weighed against the potential diagnostic yield and the patient's expressed preferences. Shared decision-making is paramount, ensuring the patient is fully informed and involved in the treatment plan. Question 4. The performance metrics show a slight increase in the time taken to reach a definitive diagnosis for patients presenting with exertional dyspnea and chest tightness. A review of a recent case reveals a 62-year-old male with a history of hypertension and hyperlipidemia who presented with these symptoms. Initial ECG showed nonspecific STT wave changes, and cardiac enzymes were within normal limits. The patient reported symptom relief with rest. Based on these initial findings, which of the following diagnostic reasoning approaches best reflects best professional practice in this context? Option A. Develop a differential diagnosis that includes stable angina, atypical presentations of pulmonary embolism and GERD, and then strategically order investigations to confirm or exclude the most likely and serious conditions first. Option B. Initiate a broad panel of investigations including pulmonary function tests, echocardiogram, and stress testing to comprehensively evaluate all potential causes of dyspnea. Option C. Focus solely on ruling out acute coronary syndrome given the patient's risk factors and symptoms, and discharge the patient with a prescription for nitroglycerin if symptoms recur. Option D. Reassure the patient that symptoms are likely benign given the normal cardiac enzymes and ECG, and advise lifestyle modifications. The correct answer is D. Reassure the patient that symptoms are likely benign given the normal cardiac enzymes and ECG, and advise lifestyle modifications. Explanation. This scenario presents a common challenge in internal medicine, where a physician must integrate evolving diagnostic information with established clinical guidelines and patient-specific factors. The professional challenge lies in avoiding premature closure of diagnostic reasoning, particularly when initial findings might suggest a common diagnosis, while simultaneously ensuring efficient and appropriate patient care. The physician must balance the need for thoroughness with the imperative to avoid unnecessary investigations or delays in definitive management. The correct approach represents best professional practice by prioritizing a systematic and comprehensive diagnostic process. It aligns with the American Board of Internal Medicine's emphasis on evidence-based medicine and the principles of diagnostic reasoning, which advocate for considering a broad differential diagnosis and actively seeking information to confirm or refute hypotheses. This approach ensures that all plausible explanations for the patient's symptoms are evaluated, minimizing the risk of missing a less common but serious condition. Adherence to established diagnostic algorithms and guidelines, as expected by the ABM, is crucial for providing high-quality, safe patient care. An incorrect approach that prematurely settles on a diagnosis without adequately exploring alternative explanations demonstrates a failure in diagnostic reasoning, specifically the cognitive bias of premature closure. This can lead to diagnostic errors, delayed treatment, and potentially adverse patient outcomes. Ethically, it represents a failure to provide the standard of care expected, as it does not involve a sufficiently thorough evaluation. Another incorrect approach, such as ordering a battery of tests without a clear diagnostic rationale, is inefficient, costly, and can lead to iatrogenic harm through false positives or unnecessary procedures. This deviates from the principle of judicious use of resources and patient safety. Professionals should employ a structured decision-making process that includes 1. Gathering a comprehensive history and performing a thorough physical examination. 2. Developing a broad differential diagnosis based on the initial findings. 3. Systematically evaluating each item on the differential, prioritizing based on likelihood and severity. 4. Ordering investigations strategically to confirm or exclude key diagnoses. And 5. Reassessing the differential and plan as new information becomes available. This iterative process, grounded in critical thinking and a commitment to patient well-being, is fundamental to sound medical practice. Question 5. The investigation demonstrates a 68-year-old male with a history of coronary artery disease and hypertension, presenting with worsening dyspnea on exertion, orthopnea, and peripheral edema over the past week. His current medications include aspirin, a statin, an ACE inhibitor, and a beta blocker. An electrocardiogram shows sinus rhythm with occasional premature ventricular contractions. Echocardiography reveals moderate left ventricular systolic dysfunction with an ejection fraction of 35%, mild mitral regurgitation, and normal left ventricular wall thickness. Which of the following diagnostic approaches is most appropriate for further evaluating the cause of his worsening heart failure symptoms? Option A. Perform a Holter monitor to assess for paroxysmal atrial fibrillation or other significant arrhythmias. Option B. Initiate aggressive intravenous diuretic therapy and monitor for symptom improvement. Option C. Schedule a coronary angiography to evaluate for new or worsening obstructive coronary artery disease. Option D. Obtain a chest X-ray to assess for pulmonary congestion and rule out pneumonia. The correct answer is B. Initiate aggressive intravenous diuretic therapy and monitor for symptom improvement. Explanation. This scenario presents a common clinical challenge in internal medicine, differentiating between the underlying etiologies of heart failure symptoms, particularly when patients have a history of coronary artery disease, CAD, and potential arrhythmias. The professional challenge lies in accurately identifying the primary driver of the patient's decompensation to guide appropriate management, avoiding premature or incorrect therapeutic interventions that could be ineffective or harmful. Careful judgment is required to synthesize clinical presentation, diagnostic findings, and patient history within the established guidelines for managing heart failure and its common comorbidities. The correct approach represents best professional practice because it prioritizes a systematic and evidence-based diagnostic pathway. By first investigating the most likely and treatable causes of worsening heart failure in a patient with known CAD, such as acute ischemia or significant valvular dysfunction, and considering the impact of potential arrhythmias on cardiac output, the physician adheres to the principles of prudent medical care. This aligns with the American Board of Internal Medicine's emphasis on comprehensive patient assessment and the application of current medical knowledge to diagnose and manage common cardiovascular diseases. It ensures that interventions are targeted to the root cause, optimizing patient outcomes and resource utilization. An incorrect approach that focuses solely on diuretic management without a thorough investigation into the underlying cause of the heart failure decompensation represents a failure to adhere to best practices. This could lead to masking a more serious underlying issue, such as ongoing myocardial ischemia, which requires specific revascularization strategies. Furthermore, initiating aggressive diuretic therapy without assessing for or addressing a contributing arrhythmia could be ineffective and potentially lead to electrolyte imbalances or further compromise cardiac function. Another incorrect approach might be to attribute all symptoms solely to chronic CAD without considering the potential contribution of a new or worsening arrhythmia, which could be managed with distinct therapeutic modalities like antiarrhythmics or pacing. These approaches fail to provide a comprehensive diagnostic workup, potentially delaying definitive treatment and negatively impacting patient prognosis, which is contrary to the ethical and professional standards expected in internal medicine. The professional decision-making process for similar situations should involve a structured approach. 1. Thoroughly review the patient's history, focusing on the timeline and nature of symptoms, previous cardiac events, and current medications. 2. Perform a comprehensive physical examination, paying close attention to signs of fluid overload, valvular abnormalities, and hemodynamic stability. 3. Utilize appropriate diagnostic tools such as electrocardiography, echocardiography, and laboratory tests to assess cardiac structure and function, identify ischemia, and evaluate for arrhythmias. 4. Consider the differential diagnoses for worsening heart failure in the context of the patient's comorbidities. 5. Develop a management plan that addresses the identified underlying causes, prioritizing interventions that are evidence-based and aligned with current clinical guidelines. 6. Continuously reassess the patient's response to treatment and adjust the plan as necessary. Question 6. The evaluation methodology shows a 55-year-old male presenting with intermittent non-exertional substernal pressure, rated 3/10 in intensity, occurring a few times a week. He has a history of hypertension and hyperlipidemia, both well controlled on medication. He denies shortness of breath, palpitations, or syncope. His physical examination is unremarkable, considering the need for initial diagnostic assessment for suspected coronary artery disease. Which of the following diagnostic test strategies is most appropriate as a first step? Option A, echocardiography without stress. Option B, resting electrocardiogram ECG. Option C, exercise electrocardiogram ECG stress testing. Option D, invasive coronary angiography. The correct answer is C, exercise electrocardiogram, ECG stress testing. Explanation: this scenario presents a common clinical challenge in cardiology, determining the most appropriate diagnostic test for a patient with suspected coronary artery disease, CAD, and atypical chest pain. The professional challenge lies in balancing the need for accurate diagnosis with patient safety, cost-effectiveness, and adherence to established clinical guidelines, which are implicitly governed by the standards of practice expected by the American Board of Internal Medicine, ABIM, for its certified physicians. Careful judgment is required to select a test that provides sufficient diagnostic yield without exposing the patient to undue risk or unnecessary expense. The correct approach represents best professional practice because it aligns with evidence-based guidelines for the evaluation of suspected CAD. Utilizing a stress test, particularly an exercise ECG stress test, in a patient with a low to intermediate pretest probability of CAD and no contraindications, is a standard, cost-effective, and relatively low-risk initial diagnostic step. This approach prioritizes a non-invasive assessment to stratify risk and guide further management, such as referral for more advanced imaging if indicated. This aligns with the ABIM emphasis on physician competence in applying current medical knowledge and best practices. An incorrect approach would be to immediately proceed to invasive coronary angiography without a prior non-invasive risk stratification. This fails to adhere to established guidelines that recommend non-invasive testing as a first-line strategy for most patients with suspected CAD. Ethically, this approach could be considered wasteful of healthcare resources and exposes the patient to the inherent risks of an invasive procedure unnecessarily. Another incorrect approach would be to rely solely on a resting ECG, which has limited sensitivity and specificity for detecting stable CAD, especially in asymptomatic or mildly symptomatic individuals. This would represent a failure to utilize a diagnostic tool with adequate discriminatory power, potentially leading to delayed diagnosis and suboptimal patient care, which is contrary to the ABIM commitment to high-quality patient outcomes. Finally, Ordering an echocardiogram without a stress component in this context might provide information about cardiac structure and function, but is not the primary tool for diagnosing inducible ischemia, thus not directly addressing the core question of CAD. Professional decision-making in similar situations should involve a systematic approach. First, assess the patient's pretest probability of CAD based on symptoms, risk factors, and demographics. Second, consider contraindications to various diagnostic modalities. Third, consult current evidence-based clinical practice guidelines, such as those from professional cardiology societies, which ABIM certification implicitly endorses. Fourth, weigh the risks, benefits, and costs of available diagnostic options. Finally, select the test that offers the highest diagnostic yield for the specific clinical question while minimizing patient risk and resource utilization. Question 7. Performance analysis shows a 65-year-old male with a history of type 2 diabetes mellitus and a recent diagnosis of hypertension and hyperlipidemia. His blood pressure is 155/95 mmHg, and his LDL cholesterol is 160 mg/dl. He has no known drug allergies and is not currently taking any medications. Based on current American Board of Internal Medicine guidelines for managing cardiovascular risk factors, which of the following initial pharmacologic approaches is most appropriate? Option A, initiate a beta blocker. Option B, initiate an ACE inhibitor and a calcium channel blocker. Option C, initiate a thiazide diuretic and a statin. Option D, initiate a statin. Correct answer is C. Initiate a thiazide diuretic and a statin. Explanation. Scenario analysis. This scenario presents a common clinical challenge involving a patient with multiple cardiovascular risk factors and a new diagnosis requiring pharmacologic management. The physician must balance efficacy, safety, potential drug interactions, and patient-specific factors, all within the established guidelines for managing hypertension and hyperlipidemia. The challenge lies in selecting the most appropriate initial therapy that addresses both conditions effectively, while minimizing adverse effects and adhering to evidence-based practice. Correct approach analysis. The correct approach involves initiating a combination therapy that targets both hypertension and hyperlipidemia with agents known for their efficacy and favorable safety profiles in this patient population. A thiazide diuretic is a first-line agent for hypertension, and a statin is the cornerstone of lipid-lowering therapy. Combining these addresses the patient's immediate needs based on current American Heart Association, AHA, and American College of Cardiology, AC, guidelines, which emphasize a stepwise approach to managing these conditions. This strategy aligns with the principles of evidence-based medicine and patient-centered care, aiming for optimal outcomes with minimal risk. Incorrect approaches analysis. Initiating only a beta blocker for hypertension without addressing hyperlipidemia fails to manage a critical cardiovascular risk factor, potentially leading to suboptimal long-term outcomes and contravening guidelines that advocate for comprehensive risk factor management. Starting only a statin without addressing the elevated blood pressure neglects a significant and immediate cardiovascular risk, which is a failure to adhere to established treatment protocol for hypertension. Prescribing a combination of an ACE inhibitor and a calcium channel blocker without considering the hyperlipidemia is incomplete management. While these are valid antihypertensives, they do not address the lipid disorder, which is equally important for cardiovascular risk reduction in this patient. Professional reasoning. Professionals should approach such cases by first identifying all active medical problems and their severity. Next, they should consult current, evidence-based guidelines, e.g., AHA/ACC guidelines for hypertension and hyperlipidemia, to determine first-line and alternative treatment options. Patient-specific factors, including comorbidities, potential drug interactions, contraindications, and patient preferences, must then be integrated into the decision-making process. A stepwise approach, often starting with the most impactful and well-tolerated therapies, is generally preferred. Regular follow-up and monitoring are crucial to assess efficacy, manage side effects, and adjust therapy as needed. Question 8. The monitoring system demonstrates a subtle but persistent elevation in a specific biomarker, along with a trend of increasing patient-reported symptoms that are not yet overtly alarming. Considering the American Board of Internal Medicine's emphasis on proactive patient management and evidence-based practice, which of the following approaches best reflects a responsible and effective strategy for risk assessment and stratification in this scenario. Option A. Initiate a comprehensive risk stratification using a validated clinical tool to categorize the patient's risk level and guide subsequent management intensity. Option B. Defer any significant changes in management or monitoring until the biomarker elevation becomes critically high or overt clinical deterioration occurs. Option C. Rely solely on the physician's clinical experience to interpret the biomarker and symptom trends, making a judgment call on the need for intervention. Option D. Implement a standardized, intensified monitoring protocol for all patients exhibiting this specific biomarker pattern, irrespective of other individual risk factors. The correct answer is A. Initiate a comprehensive risk stratification using a validated clinical tool to categorize the patient's risk level and guide subsequent management intensity. Explanation. Scenario analysis. This scenario presents a professionally challenging situation because it requires the physician to balance immediate patient needs with long-term risk management and resource allocation. The physician must interpret complex data, consider multiple potential risk factors, and make a decision that optimizes patient outcomes while adhering to established guidelines and ethical principles. The challenge lies in moving beyond a reactive approach to a proactive one, ensuring that interventions are timely and appropriate for the identified risk level. Correct approach analysis. The correct approach involves a systematic risk stratification process. This aligns with the American Board of Internal Medicine's emphasis on evidence-based medicine and patient-centered care. By utilizing a validated risk assessment tool, the physician can objectively categorize the patient's risk level. This stratification then guides the intensity and type of monitoring and intervention. This approach is best professional practice because it ensures that resources are allocated efficiently, focusing more intensive management on higher-risk individuals, thereby maximizing the potential for positive outcomes and minimizing preventable adverse events. It reflects a commitment to continuous quality improvement and adherence to established clinical pathways, which are implicitly supported by ABIM focus on physician competence and patient safety. Incorrect approaches analysis. One incorrect approach is to rely solely on the physician's subjective clinical judgment without a structured risk assessment tool. While clinical experience is invaluable, it can be prone to cognitive biases and may not consistently identify all significant risk factors, especially those that are less apparent or have a cumulative effect. This can lead to under- or overtreatment, failing to meet the standard of care expected by ABIM, which promotes objective and evidence-based decision-making. Another incorrect approach is to implement a one-size-fits-all monitoring protocol for all patients exhibiting the initial finding, regardless of their individual risk profile. This is inefficient and potentially harmful. It can lead to unnecessary interventions and anxiety for low-risk patients, while high-risk patients may not receive the level of attention they require. This deviates from the principle of personalized medicine and efficient resource utilization, which are core tenets of modern medical practice and implicitly encouraged by ABIM emphasis on effective and appropriate care. A third incorrect approach is to delay intervention until clear signs of deterioration are present. This reactive strategy misses the opportunity for early, potentially less invasive, and more effective management. It fails to leverage the predictive power of risk assessment and can lead to poorer patient outcomes and increased healthcare costs. ABIM focus on preventing complications and promoting optimal health outcomes necessitates a proactive approach to risk management. Professional reasoning. Professionals should employ a decision-making framework that prioritizes objective risk assessment. This involves 1. Identifying relevant risk factors from the monitoring data and patient history. 2. Selecting and applying a validated risk stratification tool appropriate for the clinical context. 3. Categorizing the patient into a risk stratum e.g., low, intermediate, high. 4. Tailoring the management plan, including the intensity of monitoring and the type of interventions, based on the identified risk stratum. 5. Regularly reassessing risk and adjusting the management plan as needed. This systematic process ensures that clinical decisions are evidence-based, patient-centered, and ethically sound, aligning with the high standards of the American Board of Internal Medicine. Question 9. Market research demonstrates that a significant portion of patients with severe COPD express a strong preference for complementary and alternative medicine (CAM) therapies over conventional pharmacological interventions, even when presented with evidence of the latter's efficacy. You are caring for Mr. Henderson, a 72-year-old patient with advanced COPD who has consistently refused inhaled corticosteroids and long-acting bronchodilators, instead opting for a regimen of herbal supplements and dietary changes he found online. He is experiencing increasing dyspnea and frequent exacerbations. You have discussed the evidence supporting conventional therapies and their potential to improve his quality of life and reduce hospitalizations. Mr. Henderson remains steadfast in his refusal of conventional treatment, stating his belief that modern medicine is too harsh and these natural remedies are all I need. What is the most appropriate course of action for Mr. Henderson's care? Option A. Respect Mr. Henderson's decision to pursue CAM therapies while continuing to educate him about the risks and benefits of conventional treatments and offering them again at future encounters, ensuring his understanding and capacity are periodically reassessed. Option B. Consult with Mr. Henderson's adult children to persuade them to encourage their father to accept conventional medical treatment, emphasizing the potential for his decline. Option C. Document Mr. Henderson's refusal of conventional therapy and focus solely on managing his symptoms with supportive care, without further discussion of evidence-based treatments. Option D. Initiate the prescribed conventional pharmacological treatments for COPD, explaining to Mr. Henderson that his condition is too severe to rely solely on CAM and that his refusal is not in his best medical interest. The correct answer is A. Respect Mr. Henderson's decision to pursue CAM therapies while continuing to educate him about the risks and benefits of conventional treatments and offering them again at future encounters, ensuring his understanding and capacity are periodically reassessed. Explanation. Scenario analysis. This scenario presents a significant ethical dilemma for a physician. The core challenge lies in balancing patient autonomy and informed consent with the physician's professional responsibility to provide the best possible care, especially when a patient's decision-making capacity might be compromised by their condition or beliefs. The physician must navigate the potential for coercion or undue influence, while respecting the patient's right to refuse treatment, even if that refusal seems detrimental. The physician's personal beliefs about the efficacy of the proposed treatment versus alternative therapies add another layer of complexity, requiring a commitment to evidence-based medicine and patient-centered care above personal bias. Correct approach analysis. The correct approach prioritizes a thorough assessment of the patient's understanding and capacity, coupled with a commitment to open communication and shared decision-making. This aligns with fundamental ethical principles of autonomy and beneficence, as well as the American Board of Internal Medicine's emphasis on patient-centered care and evidence-based practice. The physician must ensure the patient comprehends the risks, benefits, and alternatives to the proposed treatment, and that their decision is voluntary and free from coercion. Documenting this process meticulously is crucial for accountability and to demonstrate adherence to professional standards. Incorrect approaches analysis. One incorrect approach involves overriding the patient's wishes based on the physician's personal conviction about a superior alternative therapy. This violates patient autonomy and the principle of shared decision-making. Physicians are obligated to present evidence-based options and respect the patient's informed choice, even if it differs from the physician's preference. Another incorrect approach is to proceed with the treatment without adequately assessing the patient's understanding or capacity. This risks treating a patient against their will or without their true consent, which is a serious ethical and potentially legal violation. Finally, pressuring the patient or their family to accept a specific treatment, even with good intentions, constitutes undue influence and undermines the voluntary nature of informed consent. Professional reasoning. Professionals facing such dilemmas should employ a structured decision-making process. First, assess the patient's capacity to make decisions. If capacity is questionable, involve surrogate decision-makers according to established guidelines. Second, ensure comprehensive and understandable communication about the diagnosis, prognosis, treatment options, including risks, benefits, and alternatives, and the option of no treatment. Third, actively listen to the patient's values, beliefs, and goals of care. Fourth, document the entire process thoroughly, including discussions, assessments of understanding, and the patient's final decision. Finally, consult with colleagues or ethics committees when faced with complex or ethically challenging situations. Question 10. Quality control measures reveal that a physician has consistently prescribed a less evidence-based, but patient-preferred, treatment for a common chronic condition, deviating from the established American Board of Internal Medicine-endorsed clinical guidelines for this condition. The physician has documented the patient's preference for the alternative treatment and their understanding of the risks and benefits, but has not extensively explored why the guideline-recommended treatment might be superior in this specific case or sought formal consultation. What is the most appropriate course of action for the physician in this situation? Option A. Immediately switch to the guideline-recommended treatment, explaining to the patient that it is the standard of care and that their preference cannot override established medical evidence. Option B. Initiate a detailed discussion with the patient to explore the rationale behind their preference, thoroughly explain the evidence supporting the guideline-recommended treatment, discuss the potential risks and benefits of both approaches in the context of the patient's specific clinical picture, and collaboratively determine the best course of action, documenting the entire process. Option C. Disregard the clinical guideline entirely for this patient, as their expressed preference is sufficient justification for an individualized approach. Option D. Continue prescribing the patient-preferred treatment as long as the patient expresses satisfaction, as patient preference is the ultimate determinant of care. Correct answer is B. Initiate a detailed discussion with the patient to explore the rationale behind their preference, thoroughly explain the evidence supporting the guideline-recommended treatment, discuss the potential risks and benefits of both approaches in the context of the patient's specific clinical picture, and collaboratively determine the best course of action, documenting the entire process. Explanation. Scenario analysis. This scenario presents a professional challenge rooted in the tension between established clinical guidelines and a physician's clinical judgment, particularly when patient preferences or unique circumstances deviate from the norm. The physician must balance the imperative to adhere to evidence-based protocols, which are designed to ensure optimal patient outcomes and reduce variability in care, with the ethical obligation to respect patient autonomy and provide individualized care. The challenge is amplified by the potential for perceived or actual deviation from standard practice, which could have implications for quality of care, patient safety, and professional accountability. Correct approach analysis. The correct approach prioritizes a thorough, documented discussion with the patient about the rationale behind the guideline, the potential risks and benefits of adhering to it versus an alternative, and the patient's values and preferences. This aligns with the principles of informed consent and shared decision-making, which are cornerstones of ethical medical practice and are implicitly supported by guidelines that emphasize patient-centered care. Documenting this discussion demonstrates due diligence, transparency, and respect for the patient's autonomy, ensuring that any deviation from the guideline is a conscious, informed choice made in partnership with the patient. This approach upholds the spirit of clinical guidelines, which are intended to guide, not rigidly dictate care. Incorrect approaches analysis. An approach that rigidly adheres to the guideline without exploring the patient's specific situation or preferences fails to acknowledge the individual nature of patient care and the importance of patient autonomy. This can lead to suboptimal care if the guideline is not perfectly suited to the patient's unique needs or values, and it may erode patient trust. Ethically, it can be seen as a failure to engage in shared decision-making. An approach that immediately deviates from the guideline based solely on the physician's intuition, without a structured discussion, documented rationale, or consideration of the guideline's evidence base, risks compromising patient safety and quality of care. This could be interpreted as practicing outside of established best practices without adequate justification, potentially leading to adverse events and raising questions about professional accountability. It bypasses the systematic evaluation that guidelines are designed to provide. An approach that dismisses the guideline as irrelevant without a clear, documented reason, or without engaging the patient in a discussion about its applicability, is professionally irresponsible. Guidelines are developed through rigorous review of evidence and are intended to represent the consensus of expert opinion. Ignoring them without a sound, documented rationale undermines the principles of evidence-based medicine and can lead to inconsistent and potentially substandard care. Professional reasoning. Professionals facing such dilemmas should employ a structured decision-making process. First, thoroughly understand the relevant clinical guideline and its evidence base. Second, assess the patient's individual circumstances, values, and preferences. Third, engage in open and honest communication with the patient, explaining the guideline, its rationale, and potential alternatives, and actively listening to their concerns and goals. Fourth, collaboratively decide on a course of action, ensuring it is well documented and justifiable. If a deviation from the guideline is chosen, the rationale must be clearly articulated and supported by the patient's informed consent and the physician's clinical judgment. Question 11. Implementation of a comprehensive management plan for a patient recently discharged after hospitalization for acute decompensated heart failure with reduced ejection fraction, focusing on optimizing guideline-directed medical therapy and ensuring long-term adherence, requires which of the following initial steps? Option A. Initiate a stepwise titration of evidence-based pharmacotherapies, including an ACE inhibitor/ARB/ARNI, beta blocker, MRA, and SGLT2 inhibitor, while simultaneously providing thorough patient education on medication purpose, potential side effects, and the importance of adherence, with close outpatient follow-up scheduled. Option B. Immediately titrate all 4 pillars of guideline-directed medical therapy to their maximum tolerated doses to achieve optimal benefit as quickly as possible, without significant regard for potential adverse effects or patient tolerance. Option C. Prescribe high-dose loop diuretics to ensure complete euvolemia and instruct the patient to follow up with their primary care physician in 1 month for medication review. Option D. Discharge the patient with a written medication list and a referral to a cardiac rehabilitation program, assuming the patient will manage their complex regimen independently. The correct answer is A. Initiate a stepwise titration of evidence-based pharmacotherapies, including an ACE inhibitor/ARB/ARNI, beta blocker, MRA, and SGLT2 inhibitor, while simultaneously providing thorough patient education on medication purpose, potential side effects, and the importance of adherence, with close outpatient follow-up scheduled. Explanation. Scenario analysis. This scenario presents a common yet complex clinical challenge in managing heart failure, specifically the transition from acute decompensation to chronic management. The professional challenge lies in balancing aggressive guideline-directed medical therapy, GDMT, with patient tolerance, potential comorbidities, and the need for comprehensive education and support. The physician must navigate the nuances of initiating and titrating multiple medications, assessing for contraindications or adverse effects, and ensuring the patient understands the long-term implications of their treatment plan. This requires not just pharmacological knowledge, but also strong communication and patient-centered care skills. Correct approach analysis. The optimal approach involves a systematic, evidence-based strategy that prioritizes patient safety and adherence. This includes a thorough assessment of the patient's current clinical status, comorbidities, and potential drug interactions. Initiating GDMT for heart failure with reduced ejection fraction, HFrF, follows established guidelines, typically involving a stepwise approach to the 4 pillars of therapy. An ACE inhibitor/ARB/ARNI, a beta blocker, a mineralocorticoid receptor antagonist, MRA, and an SGLT2 inhibitor where appropriate and tolerated. Titration should be gradual, guided by clinical response, blood pressure, heart rate, and renal function. Crucially, patient education regarding medication purpose, side effects, and the importance of adherence is paramount for long-term success and preventing readmissions. This aligns with the American Board of Internal Medicine's emphasis on evidence-based practice and patient well-being. Incorrect approaches analysis. One incorrect approach would be to solely focus on diuretic therapy for symptom relief without addressing the underlying pathophysiology with GDMT. This fails to meet the standard of care for HFrEF, as diuretics provide only symptomatic relief and do not improve mortality or reduce hospitalizations. Ethically, this represents a failure to provide optimal care and could be considered a deviation from professional responsibility. Another incorrect approach would be to aggressively titrate all GDMT agents simultaneously without adequate monitoring or patient assessment. This increases the risk of adverse events such as hypotension, bradycardia, hyperkalemia, or worsening renal function, potentially leading to hospitalization or discontinuation of essential therapies. This approach demonstrates a lack of clinical judgment and disregard for patient safety, which are core tenets of medical practice. A third incorrect approach would be to discharge the patient with a complex medication regimen without providing comprehensive education or a clear follow-up plan. This significantly compromises adherence and self-management, increasing the likelihood of poor outcomes and readmission. It represents a failure in patient advocacy and education, which are critical components of effective chronic disease management. Professional reasoning. Professionals should approach this situation by first conducting a comprehensive assessment of the patient's heart failure status, including ejection fraction, symptoms, and functional capacity. They should then consult current ACC/AHA/HFSA guidelines for HFrEF management to identify appropriate GDMT. A stepwise initiation and titration of these therapies, closely monitoring for efficacy and tolerability, is essential. Patient education should be integrated throughout the process, covering medication benefits, side effects, lifestyle modifications, and the importance of follow-up appointments. A multidisciplinary approach involving pharmacists and nurses can enhance patient understanding and adherence. Question 12. Cost-benefit analysis shows that while direct visualization of the tracheobronchial tree via flexible bronchoscopy offers high diagnostic yield for certain intrapulmonary lesions, it carries inherent risks of bleeding, pneumothorax, and infection. Considering the anatomy and physiology of the respiratory system, which of the following diagnostic strategies would represent the most appropriate initial approach for a patient presenting with persistent hemoptysis and a suspicious but poorly defined opacity on chest X-ray, prioritizing patient safety and diagnostic efficacy? Option A. Obtain a high-resolution computed tomography (HRCT) scan of the chest to better delineate the opacity and surrounding lung parenchyma. Option B. Initiate a course of empiric antibiotics and await symptom resolution before further investigation. Option C. Perform a diagnostic thoracentesis to analyze pleural fluid for evidence of malignancy or infection. Option D. Proceed directly with flexible bronchoscopy to visualize the airway and obtain tissue samples. The correct answer is D. Proceed directly with flexible bronchoscopy to visualize the airway and obtain tissue samples. Explanation. This scenario presents a professional challenge because it requires a physician to balance the immediate need for diagnostic information with the potential risks and benefits of invasive procedures, all within the context of established medical guidelines and patient well-being. The physician must consider the anatomical and physiological implications of each diagnostic modality, understanding how they interact with the patient's respiratory system. Careful judgment is required to select the most appropriate and least invasive method that will yield the necessary diagnostic clarity. The correct approach represents best professional practice because it prioritizes a non-invasive diagnostic strategy that leverages advanced imaging techniques to visualize the anatomy and physiology of the respiratory system without direct intervention. This aligns with the principle of do no harm and the ethical imperative to utilize the least burdensome diagnostic tools first. Such an approach is supported by current medical guidelines that advocate for stepwise diagnostic evaluation, starting with less invasive methods before proceeding to more complex or risky interventions. This minimizes patient discomfort, reduces the risk of complications, and is often more cost-effective in the long run. An incorrect approach that immediately opts for a highly invasive procedure without exhausting less invasive options fails to adhere to the principle of proportionality in medical intervention. This could be considered a regulatory or ethical failure, as it may expose the patient to unnecessary risks, such as pneumothorax or bleeding, which are inherent to invasive procedures like bronchoscopy or thoracentesis. Furthermore, it may not be the most efficient diagnostic pathway if simpler imaging could have provided sufficient information, leading to potential waste of healthcare resources. Another incorrect approach might involve relying solely on subjective patient symptoms without objective physiological assessment, which is insufficient for accurate diagnosis and can lead to misdiagnosis and delayed appropriate treatment, violating standards of care. Professional reasoning in such situations should involve a systematic evaluation of the patient's presentation, considering the differential diagnoses. The physician should then review available diagnostic modalities, assessing their invasiveness, diagnostic yield, risks, benefits, and cost. A tiered approach, starting with the least invasive and progressing as necessary, guided by anatomical and physiological understanding, is crucial. This decision-making process should be collaborative, involving the patient in informed consent discussions about the rationale for each step and the associated risks and benefits. Question 13. Investigation of a 45-year-old male presenting with progressive fatigue weight loss, and postural dizziness reveals a serum cortisol level of 4 mcg/dl, reference range 5-25 mcg/dl. Which of the following initial diagnostic steps would best differentiate between primary and secondary adrenal insufficiency? Option A. Measure serum cortisol levels alone. Option B. Administer a low-dose dexamethasone suppression test. Option C. Administer a high-dose ACTH stimulation test. Option D. Measure serum ACTH and cortisol levels simultaneously. Correct answer is D. Measure serum ACTH and cortisol levels simultaneously. Explanation: scenario analysis. This scenario presents a challenge in differentiating between primary and secondary endocrine dysfunction based on clinical presentation and initial laboratory findings. Physician must integrate knowledge of the hypothalamic pituitary adrenal (HPA) axis and the physiological effects of cortisol deficiency to accurately diagnose the underlying cause. Misinterpreting the findings could lead to delayed or incorrect treatment, potentially causing significant patient harm. Correct approach analysis. The correct approach involves a systematic evaluation of the HPA axis. Measuring both ACTH and cortisol levels is crucial. In primary adrenal insufficiency, Addison's disease, the adrenal glands are failing, leading to low cortisol. The pituitary, sensing the low cortisol, increases ACTH production in an attempt to stimulate the adrenals. Therefore, a low cortisol with a high ACTH strongly suggests primary adrenal insufficiency. This diagnostic pathway aligns with established endocrinological principles and is the standard of care for investigating suspected adrenal insufficiency, ensuring appropriate management. Incorrect approaches analysis. Administering a high-dose ACTH stimulation test without first assessing baseline ACTH levels is premature and less informative. While this test can confirm adrenal reserve, it doesn't differentiate between primary and secondary causes as effectively as measuring ACTH alongside cortisol. This approach risks misinterpreting the results if the ACTH is already elevated due to pituitary compensation. Focusing solely on cortisol levels without assessing ACTH is insufficient. Low cortisol alone could be due to primary adrenal failure or secondary/tertiary hypopituitarism or hypothalamic dysfunction. Without ACTH measurement, the origin of the cortisol deficiency remains unclear, hindering targeted treatment. Ordering a dexamethasone suppression test is inappropriate in this context. This test is used to diagnose Cushing's syndrome, excess cortisol production, not adrenal insufficiency. Applying this test to a patient with suspected cortisol deficiency would be a misapplication of diagnostic tools and would not yield relevant information for the presenting problem. Professional reasoning. When faced with suspected endocrine dysfunction, a systematic approach is paramount. This involves understanding the hormonal axes involved, their feedback mechanisms, and the expected laboratory findings in various pathological states. The decision-making process should prioritize tests that can differentiate between potential causes, guiding the clinician towards the most accurate diagnosis and effective treatment plan. This requires a strong foundation in endocrinology and a commitment to evidence-based diagnostic strategies. Question 14. The performance metrics show a significant underutilization of a newly recommended guideline for managing a common chronic condition, despite strong evidence supporting its efficacy and improved patient outcomes. This guideline represents a shift from the current standard of care practiced by a majority of physicians in the department. What is the most appropriate approach to address this gap between evidence and practice? Option A. Issue a directive to all physicians to immediately adopt the new guideline, with a warning of potential performance review consequences for noncompliance. Option B. Focus solely on patient education to encourage patients to request the new treatment, thereby creating demand that will drive physician adoption. Option C. Initiate a departmental educational program on the new guideline, including a review of the supporting evidence, and establish a multidisciplinary committee to develop clear implementation protocols and a feedback mechanism for physician adherence and patient outcomes. Option D. Conduct a retrospective chart review to identify reasons for non-adherence, and if physician preference is the primary driver, consider delaying implementation until further consensus is reached. The correct answer is C. Initiate a departmental educational program on the new guideline, including a review of the supporting evidence, and establish a multidisciplinary committee to develop clear implementation protocols and a feedback mechanism for physician adherence and patient outcomes. Explanation. Scenario analysis. This scenario presents a common implementation challenge in healthcare where established evidence-based guidelines conflict with physician practice patterns and patient preferences. The professional challenge lies in balancing the imperative to adhere to the highest quality evidence with the realities of clinical workflow, physician autonomy, and patient-centered care. Navigating this requires not just knowledge of evidence-based medicine, but also effective communication, change management, and a commitment to continuous quality improvement. Correct approach analysis. The correct approach emphasizes a systematic, multifaceted strategy for integrating new evidence into practice. This involves a thorough review of the evidence, engaging the relevant stakeholders, physicians, nurses, pharmacists, developing clear protocols, providing education and feedback, and monitoring outcomes. This aligns with the core principles of evidence-based medicine, which advocate for the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. It also reflects the ethical obligation of physicians to provide the best possible care, which necessitates staying abreast of and implementing advancements supported by robust evidence. Regulatory frameworks, such as those implicitly guiding the American Board of Internal Medicine's focus on quality and patient safety, support such systematic approaches to improving care. Incorrect approaches analysis. One incorrect approach might involve simply mandating adherence to the new guideline without adequate physician buy-in or education. This fails to acknowledge the complexities of clinical practice and can lead to resistance, workarounds, and a superficial adoption of the guideline, undermining its intended benefits. Ethically, it disrespects physician expertise and autonomy. Another incorrect approach could be to dismiss the new evidence because it contradicts established practice or is perceived as inconvenient. This directly violates the principles of evidence-based medicine and the ethical duty to provide optimal care. It represents a failure to engage with the scientific process and a potential disservice to patients. A third incorrect approach might be to implement the change piecemeal or without a clear plan for monitoring and evaluation. This can lead to inconsistent application, missed opportunities for improvement, and an inability to assess the true impact of the change, thereby failing to meet the standards of quality improvement and evidence-based practice. Professional reasoning. Professionals should approach such implementation challenges by first understanding the evidence thoroughly. Then, they must engage in a collaborative process with their colleagues to assess feasibility and develop a practical implementation plan. This plan should include clear communication, education, and a robust system for monitoring adherence and outcomes. Continuous feedback and iterative refinement are crucial. This systematic approach ensures that evidence-based practices are adopted effectively and sustainably, ultimately benefiting patient care. Question 15. Risk assessment procedures indicate that a 55-year-old male with a history of well-controlled hypertension, a family history of premature coronary artery disease, and a sedentary lifestyle presents for his annual physical. His current lipid panel shows a borderline elevated LDL cholesterol. Which of the following approaches best guides the next steps in his cardiovascular risk management? Option A. Advise the patient that his risk is likely low given his well-controlled hypertension and borderline LDL, and no further intervention is immediately necessary. Option B. Calculate his estimated 10-year atherosclerotic cardiovascular disease, ASCVD, risk using a validated tool, and discuss the results with the patient to inform shared decision-making regarding lifestyle modifications and potential pharmacotherapy. Option C. Focus solely on optimizing his hypertension management, as this is his most significant known cardiovascular risk factor. Option D. Prioritize addressing his current borderline elevated LDL cholesterol with aggressive statin therapy without further comprehensive risk stratification. The correct answer is B. Calculate his estimated 10-year atherosclerotic cardiovascular disease ASCVD risk using a validated tool, and discuss the results with the patient to inform shared decision-making regarding lifestyle modifications and potential pharmacotherapy. Explanation. This scenario presents a professionally challenging situation because it requires the physician to integrate multiple pieces of information, including patient history, physical examination findings, and laboratory results, to accurately assess cardiovascular risk. The challenge lies in moving beyond a single diagnostic label to a comprehensive understanding of the patient's overall risk profile, which is crucial for guiding appropriate preventive strategies and management decisions. The American Board of Internal Medicine, ABIM, emphasizes a holistic approach to patient care, requiring physicians to synthesize diverse data points to make informed clinical judgments. The correct approach represents best professional practice because it aligns with the ABIM commitment to evidence-based medicine and patient-centered care. By utilizing validated risk stratification tools, such as the Asked Risk Estimator Plus, and considering all relevant clinical factors, the physician is employing a systematic and objective method to quantify the patient's future risk of cardiovascular events. This approach ensures that management decisions are tailored to the individual patient's risk level, promoting effective primary and secondary prevention strategies. This aligns with ethical principles of beneficence and non-maleficence by maximizing potential benefits and minimizing harm through personalized care. An incorrect approach that focuses solely on a single risk factor, such as hypertension, without a broader risk assessment, fails to capture the cumulative impact of multiple contributing factors. This can lead to underestimation or overestimation of overall cardiovascular risk, potentially resulting in suboptimal treatment decisions. Ethically, this represents a failure to provide comprehensive care and could violate the principle of justice by not treating patients equitably based on their full risk profile. Another incorrect approach that relies solely on patient perception of risk, without objective assessment, is professionally unacceptable as it introduces subjectivity and can lead to significant discrepancies between perceived and actual risk, hindering effective management. This disregards the physician's responsibility to provide evidence-based guidance. A third incorrect approach that prioritizes immediate symptom relief over long-term risk assessment neglects the fundamental goal of preventive cardiology. While symptom management is important, it should be integrated within a broader strategy to mitigate future cardiovascular events. This approach may be seen as a failure to uphold the physician's duty to promote long-term health and well-being. Professional decision-making in similar situations requires a structured approach. First, gather all relevant patient data, including demographics, medical history, family history, lifestyle factors, physical examination findings, and laboratory results. Second, utilize validated risk assessment tools appropriate for the patient's age and demographic. Third, critically evaluate the results of the risk assessment in the context of the individual patient's clinical presentation and preferences. Fourth, engage in shared decision-making with the patient, discussing their risk, treatment options, and potential benefits and harms. Finally, develop and implement a personalized management plan that addresses all modifiable risk factors. Question 16. The control framework reveals a patient presenting with a constellation of symptoms including fatigue, intermittent abdominal discomfort, and a recent unintentional weight loss. The physician has reviewed the patient's initial laboratory results, which show mild anemia and elevated liver enzymes. Considering the need for a comprehensive patient assessment, which of the following approaches best reflects the principles of internal medicine practice? Option A. Developing a differential diagnosis that considers various etiologies for the anemia, liver enzyme elevation, and weight loss, and then strategically ordering further investigations to systematically rule in or rule out the most likely diagnoses. Option B. Reassuring the patient that fatigue and mild abdominal discomfort are common and likely benign, and advising them to monitor symptoms without further diagnostic workup at this time. Option C. Immediately ordering a broad-spectrum antibiotic to address potential underlying infection given the nonspecific symptoms. Option D. Focusing solely on the elevated liver enzymes and scheduling a liver biopsy without further investigation into the patient's gastrointestinal history or other systemic symptoms. The correct answer is C. Immediately ordering a broad-spectrum antibiotic to address potential underlying infection given the nonspecific symptoms. Explanation. This scenario presents a professional challenge due to the inherent complexity of a comprehensive patient assessment, particularly when multiple diagnostic modalities and patient history elements are involved. The physician must synthesize diverse information, weigh potential diagnoses, and prioritize further investigation while ensuring patient safety and adherence to established clinical guidelines. Careful judgment is required to avoid premature closure or over-reliance on a single piece of data. The correct approach represents best professional practice by prioritizing a systematic and evidence-based evaluation. This involves integrating the patient's subjective complaints with objective findings from the physical examination and initial diagnostic tests. Physician's responsibility, as guided by the American Board of Internal Medicine's ABM, commitment to physician competence and patient well-being, is to develop a differential diagnosis and then strategically select the next steps that will most efficiently and effectively clarify the diagnosis while minimizing patient risk and resource utilization. This aligns with the ABM emphasis on lifelong learning and the application of current medical knowledge. An incorrect approach that focuses solely on a single symptom without considering the broader clinical picture represents a failure to conduct a comprehensive assessment. This could lead to overlooking significant comorbidities or alternative diagnoses, potentially resulting in delayed or incorrect treatment, which is contrary to the ABM core principles of patient-centered care and diagnostic accuracy. Another incorrect approach that relies heavily on a single, potentially misleading, diagnostic test without corroborating evidence or further clinical correlation demonstrates a lack of critical appraisal of diagnostic information. This can lead to unnecessary interventions or a false sense of diagnostic certainty, violating the ethical obligation to practice with due diligence and to avoid harm. A third incorrect approach that prematurely dismisses a significant aspect of the patient's history or physical exam due to a perceived less common etiology neglects the fundamental principle of thoroughness in assessment, potentially missing critical diagnostic clues and failing to meet the standards of internal medicine practice. Professionals should employ a decision-making framework that begins with active listening and thorough history-taking, followed by a systematic physical examination. This should then be integrated with available diagnostic data to formulate a list of potential diagnoses, differential diagnosis. Subsequent steps should be guided by the likelihood of each diagnosis, the potential impact of missing a diagnosis, and the diagnostic yield and risk of further investigations. This iterative process ensures that the assessment remains comprehensive and evolves as new information becomes available. Question 17. The analysis reveals a patient presenting with chronic cough and dyspnea on exertion. The physician is considering the next steps in the diagnostic workup. Which of the following approaches best reflects the judicious and evidence-based utilization of diagnostic tests in this scenario, adhering to the principles of internal medicine practice? Option A. Recommend a high-resolution CT scan of the chest and a bronchoscopy without prior spirometry to investigate the cause of the cough and dyspnea. Option B. Order a comprehensive panel of pulmonary function tests, including spirometry and a chest CT scan to thoroughly evaluate the respiratory system. Option C. Prescribe empirical treatment for common respiratory infections and reassess symptoms in 2 weeks without further diagnostic testing. Option D. Initiate a broad range of imaging studies, including abdominal ultrasound and brain MRI, to rule out less common systemic causes of the symptoms. The correct answer is B. Order a comprehensive panel of pulmonary function tests, including spirometry and a chest CT scan to thoroughly evaluate the respiratory system. Explanation. This scenario presents a common implementation challenge in internal medicine, balancing the need for timely and accurate diagnostic information with the practical constraints of patient care and resource allocation. The physician must navigate the complexities of ordering appropriate diagnostic tests, ensuring they are medically indicated and interpreted correctly, while also considering patient safety, cost-effectiveness, and adherence to established clinical guidelines. The professional challenge lies in making an informed decision that optimizes patient outcomes without unnecessary testing or delay. The correct approach represents best professional practice because it prioritizes a systematic and evidence-based diagnostic strategy. This involves a thorough clinical assessment to guide the selection of diagnostic tests, ensuring that spirometry is considered for suspected pulmonary conditions and imaging studies are utilized judiciously based on specific clinical indications. This aligns with the principles of responsible medical practice, emphasizing the judicious use of resources and avoiding overtesting, which can lead to patient anxiety, unnecessary costs, and potential harm from incidental findings. Adherence to established guidelines for the appropriate use of diagnostic tests is a cornerstone of quality patient care and professional accountability. An incorrect approach that involves ordering a broad battery of imaging studies without a clear clinical rationale fails to meet professional standards. This can be considered a violation of the principle of medical necessity, potentially leading to unnecessary radiation exposure, increased healthcare costs, and the risk of discovering incidental findings that may not be clinically significant, causing patient distress and further unnecessary investigations. Another incorrect approach, such as relying solely on patient self-report for the necessity of advanced imaging without a physician-led clinical assessment, bypasses the physician's critical role in interpreting symptoms and formulating a diagnostic plan, potentially leading to misdiagnosis or delayed appropriate care. Furthermore, neglecting to consider spirometry when indicated for respiratory symptoms represents a failure to utilize a fundamental diagnostic tool for pulmonary disease, potentially delaying diagnosis and appropriate management. The professional decision-making process for similar situations should involve a structured approach. 1. Thoroughly gather patient history and perform a physical examination to identify key symptoms and signs. 2. Formulate a differential diagnosis based on the clinical presentation. 3. Determine which diagnostic tests, including spirometry or specific imaging studies, are most likely to confirm or refute the leading diagnoses, considering their sensitivity, specificity, and clinical utility. 4. Consult relevant clinical practice guidelines to ensure the appropriateness and efficiency of the chosen diagnostic pathway. 5. Discuss the rationale for testing and potential findings with the patient. 6. Critically interpret the results of diagnostic tests in the context of the patient's overall clinical picture. Question 18. The performance metrics show that a 62-year-old male patient with type 2 diabetes mellitus, who has been adherent to his prescribed metformin 1000 mg twice daily for the past 6 months, continues to have an HbA1c of 8.5%. His baseline HbA1c was 7.8%. He denies any significant side effects from the metformin and has no known contraindications to other oral hypoglycemic agents. His estimated glomerular filtration rate is 70 ml/min/1, 73 m2. Which of the following represents the most appropriate next step in managing this patient's glycemic control? Option A. Initiate basal insulin therapy. Option B. Switch to a different oral hypoglycemic agent with a similar mechanism of action. Option C. Increase the dose of metformin to the maximum recommended daily dose. Option D. Add a sulfonylurea agent to the current metformin regimen. The correct answer is D. Add a sulfonylurea agent to the current metformin regimen. Explanation. Scenario analysis. This scenario presents a common clinical challenge involving a patient with type 2 diabetes mellitus experiencing suboptimal glycemic control despite adherence to a prescribed oral hypoglycemic agent. The professional challenge lies in determining the most appropriate next step in management, balancing efficacy, safety, patient factors, and adherence to established clinical guidelines. The physician must consider the pharmacology of available agents, potential side effects, contraindications, and the patient's individual characteristics. Correct approach analysis. The correct approach involves a thorough reassessment of the patient's adherence, lifestyle factors, and the current medication's efficacy and tolerability. If adherence is confirmed and the current medication is maximally tolerated and dosed, then escalating therapy with a second agent that has a complementary mechanism of action is indicated. This aligns with Standard American Board of Internal Medicine, ABM, guidelines for diabetes management, which emphasize a stepwise approach to achieving glycemic targets. The choice of the second agent should be guided by evidence-based guidelines, considering factors such as cardiovascular risk, renal function, risk of hypoglycemia, weight effects, and cost. This approach prioritizes patient safety and optimal clinical outcomes by systematically addressing the reasons for treatment failure and implementing evidence-based interventions. Incorrect approaches analysis. One incorrect approach would be to immediately increase the dose of the current oral hypoglycemic agent without a comprehensive reassessment. This fails to acknowledge that the current agent may have reached its maximal efficacy or that other factors are contributing to poor control. It could lead to increased side effects without significant benefit and is not a systematic approach to optimizing therapy. Another incorrect approach would be to switch to a different oral hypoglycemic agent with a similar mechanism of action without first exploring other therapeutic classes. This would not offer a significant advantage in terms of glycemic control if the initial agent's mechanism was insufficient. It also overlooks the opportunity to introduce agents with different benefits, such as cardiovascular or renal protection, which are often crucial in managing type 2 diabetes. A third incorrect approach would be to initiate insulin therapy without first optimizing oral or non-insulin injectable agents, unless there are specific contraindications to other classes or very high baseline A1C. This is generally considered a more advanced step and may be associated with a higher risk of hypoglycemia and weight gain if not carefully managed, and it bypasses potentially effective and less burdensome intermediate options. Professional reasoning. When faced with suboptimal glycemic control, the professional decision-making process should involve a systematic evaluation. First, confirm adherence to the current regimen and assess for any contributing lifestyle factors. Second, evaluate the current medication's appropriateness, including dosage, mechanism of action, and potential for further titration or side effects. Third, consider the patient's comorbidities, risks e.g., hypoglycemia, cardiovascular events, renal disease, and preferences. Finally, consult current evidence-based guidelines to select the most appropriate next therapeutic step, which may involve adding a new agent with a complementary mechanism or a different class of medication, or considering alternative delivery methods. Question 19. Research into the optimal method for communicating cardiovascular disease risk to a patient with multiple modifiable risk factors, but no current symptoms, suggests that a physician's approach should prioritize clarity, objectivity, and patient engagement. Considering the principles of evidence-based medicine and patient-centered care, which of the following strategies best aligns with professional guidelines for risk assessment and patient counseling in internal medicine? Option A. Rely on the physician's clinical experience and subjective assessment of the patient's risk factors to provide a general overview of potential future health concerns. Option B. Present the patient with raw statistical data regarding the prevalence of cardiovascular disease in the general population without specific personalization. Option C. Focus solely on addressing any immediate, non-cardiovascular related complaints the patient may have, deferring any discussion of cardiovascular risk to a future, symptom-driven encounter. Option D. Utilize a validated cardiovascular risk prediction tool to quantify the patient's estimated 10-year risk of atherosclerotic cardiovascular disease, followed by a discussion of the results, lifestyle modifications, and potential pharmacologic interventions tailored to their individual risk profile. The correct answer is D. Utilize a validated cardiovascular risk prediction tool to quantify the patient's estimated 10-year risk of atherosclerotic cardiovascular disease, followed by a discussion of the results, lifestyle modifications, and potential pharmacologic interventions tailored to their individual risk profile. Explanation. This scenario presents a professional challenge due to the inherent uncertainty in predicting future health events and the ethical imperative to provide accurate, unbiased information to patients. The physician must balance the potential for anxiety and distress caused by risk assessment with the patient's right to informed decision-making. Careful judgment is required to select the most appropriate method for communicating risk, ensuring it is understandable and actionable, without being overly alarming or dismissive. The correct approach represents best professional practice because it prioritizes patient autonomy and shared decision-making, aligning with the American Board of Internal Medicine's emphasis on comprehensive patient care and evidence-based practice. Utilizing a validated risk prediction tool, such as the Asked Risk Estimator Plus, provides an objective, data-driven assessment of future cardiovascular risk. This tool, developed and endorsed by reputable medical organizations, offers a standardized and reliable method for quantifying risk. Presenting this information to the patient, followed by a discussion of lifestyle modifications and potential pharmacologic interventions tailored to their individual risk profile, empowers the patient to participate actively in their healthcare decisions. This aligns with ethical principles of beneficence, acting in the patient's best interest by providing relevant information, and non-maleficence, avoiding undue harm by presenting risk in a balanced and actionable manner. Furthermore, it adheres to guidelines from professional bodies that advocate for proactive cardiovascular risk assessment and management. An incorrect approach that relies solely on the physician's subjective impression of risk fails to meet professional standards. This method is prone to bias, lacks objectivity, and does not provide a quantifiable basis for discussion, potentially leading to under- or overestimation of risk. Ethically, it undermines the principle of informed consent by not providing the patient with the most accurate and comprehensive information available. It also deviates from evidence-based practice, a cornerstone of internal medicine. Another incorrect approach that involves presenting raw statistical probabilities without context or explanation is also professionally unacceptable. While seemingly objective, raw statistics can be overwhelming and difficult for patients to interpret, leading to confusion, anxiety, or a sense of helplessness. This approach neglects the physician's ethical duty to ensure patient understanding and fails to facilitate shared decision-making. It can be perceived as a failure to communicate effectively and empathetically, potentially eroding patient trust. A further incorrect approach that focuses exclusively on immediate symptoms without considering underlying risk factors ignores the proactive and preventative aspects of internal medicine. While addressing acute concerns is vital, neglecting to assess and discuss long-term risk factors for conditions like cardiovascular disease represents a failure to provide comprehensive care. This approach is ethically problematic as it may miss opportunities to prevent future morbidity and mortality, thus not fully acting in the patient's best interest. It also falls short of the professional expectation to manage patients holistically. Considering both acute and chronic health concerns, the professional decision-making process for similar situations should involve a systematic approach. First, identifying the patient's presenting concern and relevant medical history. Second, determining if a validated risk assessment tool is appropriate for the clinical context. Third, utilizing the tool to generate objective risk data. Fourth, engaging in a clear, empathetic, and patient-centered discussion about the findings, including potential benefits and harms of interventions. And finally, collaboratively developing a management plan that respects the patient's values and preferences. Question 20. Examination of the data shows a 68-year-old male with stage 3B chronic kidney disease, CKD, on a stable regimen of lisinopril, furosemide, and metformin. He reports good adherence to his medications. The physician is reviewing his chart for his annual CKD assessment. Which of the following actions best reflects current best practices for managing this patient's chronic kidney disease according to the American Board of Internal Medicine's focus on quality patient care? Option A. Rely solely on the patient's self-report of adherence to determine the appropriateness of his current medication regimen. Option B. Discontinue metformin due to its potential for lactic acidosis in patients with impaired renal function, without further investigation. Option C. Initiate a comprehensive review of all current medications for potential nephrotoxicity or the need for dose adjustment based on the patient's current eGFR, consulting relevant guidelines for CKD management. Option D. Continue all current medications as prescribed, as the patient reports good adherence and his CKD is stable. The correct answer is D. Continue all current medications as prescribed, as the patient reports good adherence and his CKD is stable. Explanation. Scenario analysis. This scenario presents a common clinical challenge in managing chronic kidney disease, CKD, where a patient's medication regimen requires careful consideration of potential renal impact and adherence to established guidelines. The physician must balance therapeutic efficacy with patient safety, particularly concerning nephrotoxic agents and the need for ongoing monitoring. The professional challenge lies in interpreting the available data, applying current evidence-based guidelines for CKD management, and making a judicious decision that prioritizes patient well-being while adhering to regulatory expectations for quality patient care. Correct approach analysis. The correct approach involves a comprehensive review of the patient's current medications, specifically identifying any agents known to be nephrotoxic or require dose adjustment in CKD. This includes assessing the indication for each medication, the current renal function, eGFR, and the potential for drug-drug interactions or additive nephrotoxicity. The physician should then consult current American Board of Internal Medicine, ABM guidelines and relevant literature for best practices in CKD management, which emphasize minimizing nephrotoxic exposures and optimizing renally cleared medications. This approach aligns with the ABM commitment to promoting high-quality, evidence-based internal medicine practice and patient safety. Incorrect approaches analysis. An approach that involves continuing all current medications without reassessment of renal impact or potential nephrotoxicity fails to meet the standard of care for CKD management. This could lead to iatrogenic kidney injury or accelerated CKD progression, representing a failure to adhere to best practices in patient safety and potentially violating implicit regulatory expectations for vigilant medication management in vulnerable patient populations. Another incorrect approach would be to arbitrarily discontinue all medications without a clear clinical rationale or consideration of the patient's underlying conditions. This could destabilize other chronic conditions, leading to adverse health outcomes and demonstrating a lack of systematic and evidence-based decision-making, which is contrary to the principles of responsible medical practice expected by the ABM. Finally, an approach that relies solely on patient self-report without objective assessment of renal function or medication adherence overlooks critical data points necessary for safe and effective CKD management. This can lead to misjudgments about the patient's status and the appropriateness of their treatment, potentially resulting in suboptimal care and increased risk. Professional reasoning. Professionals should adopt a systematic approach to medication management in CKD. This involves 1. Thoroughly reviewing the patient's medical history, including all current medications and their indications. 2. Obtaining and interpreting objective data, such as laboratory results, e.g., eGFR, electrolytes, and imaging if relevant. 3. Consulting current, evidence-based guidelines and reputable medical literature for specific recommendations on managing CKD and its associated comorbidities, including medication selection and dosing. 4. Engaging in shared decision-making with the patient regarding treatment plans, considering their preferences and ability to adhere. 5. Documenting the rationale for all clinical decisions and treatment modifications.